Very good morning, respected Emeritus Chairperson Dr. M.L. Sonkar sir, Vice Chancellor Dr. Achal Gulati sir, Principal sir, MS sir, respected faculty member and dear students. Today I am introducing my Department of Plastic and Reconstructive Surgery. In our department, we are 6 faculty members, myself Dr. Buddhi Prakash, Professor and Head, Dr. Manish Singhal, Dr. Manish Jain, both are professor, Dr. Umesh Bansal, who recently joined as senior consultant in our department, who has done more than 4600 free flaps in last 10 years, who was working as Bhagwan Mahavir Cancer Hospital, past. Dr. Govind, who is working as associate professor in our department, and Dr. Prabhu Shankar, who also recently joined as an assistant professor in our department. With the blessing and full support of Emeritus Chairperson sir and our Chairperson Dr. Vikas Chandra Sonkar sir, we are equipped with high-end instrument, microscope, which has very vital role in our department by doing free flaps and micro surgeries. We have 2 microscopes. One is Carl Zeiss, who has 15 times magnification, and Leica, who has 30 times magnification. Plastic surgery department started in 2013, and I am lucky and blessed to work in this premier and tertiary institute since beginning of this department. MCH course started in 2016 with 1 seat. Number of MCH seats at present 4 seats per year. Total number of MCH passed are 10, and currently 7 MCH students are pursuing degree. We have very good OPD numbers, average 400 to 450 per month, and average number of cases operated per month is 120 to 130. More than 100 publications in national and international journals are there of our faculty and residents. What we do in plastic surgery? When ray of hope is not visible by broad eyes, then plastic surgeon sees or create that ray of hope by microscopic eyes. We do treatment of burns. All burn cases are admitted under plastic surgery department. Microvascular surgery, we have done more than 2500 free flaps in last 5 years, on an average 25 to 30 per month, under guidance of Dr. Manish Jain. He is doing tremendous work in microvascular surgery and free flap since 5 years. We are doing brachial plexus surgeries, congenital anomalies like cleft lip, cleft palate. All congenital hand anomalies are treated and operated in plastic surgery department. Hand surgeries like traumatic, nerve, vascular, replantation, and all hand surgeries are done in plastic surgery department. Facial-maxillary surgeries, breast and other aesthetic surgeries like rhinoplasty and genital aesthetic surgeries, and general plastic surgeries done under our department. Now I invite Dr. Harprabhjot Kaur to present the case. Thank you. Thank you so much.
Thank you, sir. Good morning, respected dignitaries, esteemed faculty, and my dear colleagues. I am Dr. Harprabhjot, Senior Resident in the Department of Plastic and Reconstructive Surgery. Will be presenting on microvascular reconstruction in limb salvage, preserving form and function, under the guidance of Dr. Manish Jain, Professor in the Department of Plastic and Reconstructive Surgery. A 22-year-old male resident of Ajmer Road, Jaipur, who was working in a private job, sustained road traffic accident on 5th of January following the collision between bike and pickup truck, resulting in soft tissue and bone injuries to the left lower limb. Initially, he was managed conservatively with slab application and dressing at an outside private hospital, from where he was referred to another hospital. Following the initial injury, the patient then underwent a staged management. On 6th of January, he underwent closed reduction and internal fixation with intramedullary nailing of the left femur at the outside private hospital where he was referred. The left image shows the pre-op radiographs of the left thigh showing the femur shaft fracture. On the right side, it is the post-op image which shows the intramedullary nailing with distal locking screws in place done in the outside hospital. From the above images, we can conclude that the alignment of the femur appears to be reasonably maintained. Subsequently, on 7th of January, debridement was performed for the open tibial fracture and an external fixator was applied to achieve the skeletal stabilization. Since the skeletal stabilization is utmost before any further procedure management. However, despite fixation of the femur, the tibial fracture remains a concern for all of us since clinically there is a context of open injury and a soft tissue damage. Following the skeletal stabilization, patient was examined clinically and was found to have a cold limb with no pulse oximetry signal and absent peripheral pulses. After stabilization, he was planned and performed for CT lower limb angiography. He then took LAMA and went to another corporate hospital. Now this slide outlines the critical period in the patient's clinical course. On the day 7 of trauma, that is on 12th of January, he underwent slab readjustment for the left leg at the outside corporate hospital. Following the adjustment, patient was monitored for 5 days on anticoagulant injections, antibiotics and antipyretics for fever. Despite this, his condition did not improve and the gangrenous changes were observed in the left foot from the day 10 of trauma, that is from 15th of January during his hospital stay. On the day 12 of trauma, the patient was advised amputation in the same outside corporate hospital after seeking opinion from 3 to 4 surgeons. Patient then again took LAMA from that hospital and came to Mahatma Gandhi Hospital for further management. Now at our institute, now this slide details the patient's presentation upon arrival at our institute at around 3 p.m. He was noted to be hemodynamically stable. Physical examination of the left leg revealed critical signs of vascular compromise. As seen in the accompanying photograph, the external fixator was already seen in situ. There was an open wound over the medial aspect of lower 1/3 of the left leg with no pulse oximetry signal. Peripheral pulses were non-palpable and non-audible on handheld Doppler. Interestingly, the sensory functions were intact, namely the posterior tibial nerve, which was checked by soft touch over the medial and the lateral aspect of the left foot. As per the guidelines, if the nerve is found to be intact, there is still a viable window for revas, followed by motor functions which were also intact. This slide provides the visual clinical evidence supporting the diagnosis of a threatened ischemic limb, which, according to the Rutherford classification of limb ischemia, falls under class 2. Now, can anyone think of any possible injuries on the basis of this? Absolutely correct. This highlights our assessment focusing on the specific findings that led to the diagnosis of posterior tibial artery. Now, since we can see the zone of trauma was located over the medial aspect of lower 1/3 of left leg. So, according to this, the posterior tibial artery injury could be suspected based upon its anatomical course. This shows the computed tomography angiographic imaging of the lower limb, which was done in the outside hospital as I had already detailed after the post-op external fixation for tibial fracture. The purpose was to evaluate the vascular status of the injured limb. According to this, we can see in the zoomed out photograph that there was preservation of the proximal arterial circulation, indicating that the major vessels above the knee were patent. However, there is poor visualization and non-opacification of the distal vessels below the zone of trauma in the left foot. In this CT image, we can see that the proximal vessels, namely the common iliac, external iliac, internal iliac, common femoral, deep femoral, superficial femoral and popliteal, they appear to be patent bilaterally, since the flow is maintained down the thigh to the knee. However, on the left side, there is poor visualization of the distal vessels, namely the anterior tibial artery, the posterior tibial artery, basically near the zone of trauma where we had post-op screws for external fixator. Now we can see as the dorsalis pedis artery is non-opacified, so we can conclude that the plantar arch was non-patent, thus confirming the posterior tibial artery injury. This outlines the surgical escalation from the initial assessment to the emergency intervention as the patient arrived us on day 12, that is on 17th of January 2026. Patient was taken in the OT in 1.5 hours. In the intro we had clinical findings which were confirmed. The posterior tibial artery, which was suspected clinically to be transected near the zone of trauma over the medial aspect, was confirmed, but had a long segment gap of 7 to 8 centimeters between the proximal and the distal ends. Also, the posterior tibial nerve was found to be intact, which has already been proven, according to the guidelines, that it is a prerequisite for a functional limb salvage. It was also found that the fracture ends of the tibial fracture, they were malaligned. So this emphasized a multidisciplinary coordination with the orthopedic and the cardiothoracic vascular team. Now I would like to invite Dr. Rohan, junior resident in the Department of Orthopaedics, to highlight the case further.
Thank you, boss. Good morning, respected dignitaries, esteemed faculty members, my seniors. Okay, sorry. So as we got an intraoperative call, we looked at the X-ray as well as intraoperatively, and we found a tubular external fixator was already applied for a compound shaft tibia fracture. The proximal pins that were placed were too far deep, passing through the bone into the soft tissues, and the tibial shaft was malaligned. So what we did was the proximal Schanz pins, which was protruding deep inside the soft tissues, were retracted, and proper bowl alignment was achieved, and an external fixator was readjusted. Now I would like to call Dr. Harprabhjot to take the case forward. Thank you.
Thank you, Dr. Rohan. Following the skeletal alignment, we proceeded further. Initially, the procedure was performed jointly with the cardiothoracic vascular team, ensuring optimal vascular control. We then proceeded with embolectomy with Fogarty catheter, followed by revascularization using an interposition graft that was taken by the right great saphenous vein from the opposite limb. This was completed with end-to-end anastomosis to restore the distal blood flow. Finally, to protect the repaired vessels, we provided a soft tissue coverage using a hemisoleus flap over the medial aspect. Now I would like to invite Dr. Vini from the cardiothoracic vascular team to take the case further.
Thank you, Dr. Harprabhjot. Good morning, everyone. I am Dr. Vini Mehta, senior resident from the Department of CTVS. I will speak on our intervention in this case. A brief recap of the case. He was a 22-year-old male with a history of road traffic accident. He was lying on stretcher, hemodynamically stable. On local examination, external fixators were present over the left leg, along with an open wound over the medial aspect. There was patchy discoloration over the plantar and the dorsum of the aspect of the foot. The distal peripheral pulses were absent. Sensory and motor functions were intact, so it belonged to the Rutherford class 2A of limb ischemia, indicative of urgent revascularization. CT angiography was definitive for posterior tibialis artery and anterior tibialis artery transection. So for the repair of the artery, commonly used grafts are the homograft, allograft, PTFE and Dacron. For the traumatic vessel injuries, biological grafts are ideal as there is less rate of infection and less rate of thrombus formation. As well as the homografts are easily available. The tissue grafts have no immune-mediated reaction. There is protection from thrombus formation because of the presence of native intimal layer. There is less size discrepancy at the site of anastomosis, and the pulsatile flow will be maintained. The PTFE and the Dacron graft, on the other hand, they will require anticoagulation throughout and will have higher risk of infection. So therefore, in this case, the ideal graft which we can use is homograft, and in that also, saphenous vein is ideal to harvest. So we have gone for surgical repair of the vessel using a graft, that is great saphenous vein as a homograft. Now we move to the operative steps. After shifting the patient to the operation theatre, securing the ventilation and sedation, low dose heparin was given to prevent thrombus formation at the site of proximal clamping. And then after that, incision was extended over the open wound. Transected vessel ends were identified proximally and distally, and embolectomy was done at both the sites, proximally and distally, using a Fogarty's catheter. Now we move to the other limb to harvest the homograft. The conduit used in this case was a great saphenous vein. We will see a small video of that. For this, we painted and draped the opposite limb. Incision was given over a medial aspect of the leg, proximal to the medial malleolus, and then the vein was identified. After identifying the vein, the incision was extended while tracing the vein below. The pinpoint bleeders on the way are addressed using artery forceps for bloodless field, which will be tied later on using silk threads. Now we are extending the incision to have an adequate length of the graft. Assuring the hemostasis in between. Then we put a small, then we are looping the saphenous vein using a silk thread. Now we put a small incision over the vein to access the lumen, through which a non-traumatic cannula will be inserted. This cannula is secured using silk thread. Now we are pushing heparinized solution of blood and saline to prevent thrombus formation and checking any caliber changes in the vessel. The perforator branches on the way are identified and doubly tied using silk threads and then separated. The other end will be tied later on using silk thread. After this, we will dissect the vein from the tissue below. Then we free the distal end of the vein and the dissection is completed using fine scissors. And any branches left on the way are tied using silk threads. Smaller branches are tied with a single thread and larger branches are tied with a double thread. And the other end will be taken care of later on. Then after this, we freed the distal end after confirming the adequate length of the graft using fine scissors. Then we move to the operative site. Here the proximal end of the artery is anastomosed to the vein using Prolene 70 sutures in continuous manner. The anastomosis has already been done. We are checking for the anastomotic leak from the site after placing a bulldog clamp over the distal end of the vein. Then we completed the distal anastomosis. This is a sound of Handel Doppler which was used to confirm the flow around the vessel. The wound was left open, but the graft was covered with a soft tissue for its protection from getting dried up and any traumatic injury. We advised anticoagulation post-operatively. Heparin infusion was started after a few hours after confirming there is no chances of bleeding at the rate of 500 international units per hour. Heparin infusion is titrated according to maintain the APTT twice the normal range. After 24 hours of the surgery, tablet acetrom and ecosprin is started till the time it is continued till the time the epithelialization of the intimal layer is completed. And anticoagulation is needed for minimum of 3 weeks and up to 6 months. The heparin infusion is stopped once the INR is around 2 to 2.5 and the patient is handed over to the Department of Plastic Surgery for further management. Now I call upon Dr. Harprabhjot Kaur to take the discussion forward. Thank you.
Thank you, Dr. Vini. In the next slide, this highlights the further post-operative course following the surgical repair of the arterial injury. It focused on clinical indicators which were used to confirm the successful revascularization during the early recovery phase for 2 days in the surgical ICU. Here we noted that the patient was hemodynamically stable in the post-op period. On clinical examination, the left foot was warm on touch with capillary refill present in all the toes. The saturation recorded was 94 to 96% in all toes with bright red on pinprick in all toes. Foot is positioned and elevated with supportive bandaging and external fixator in situ as seen in the accompanying photograph. In the further post-operative course in the ward, patient underwent conservative management with clinical monitoring and regular dressings. The limb elevation with 2 to 3 pillows was ensured. The anticoagulation therapy was continued. In the accompanying photograph, we can see that, that there was a normal healthy skin color of the left foot with blackening in the dorsum and sole of midfoot, and a hemisoleus flap which was initially used in the intra-op period to cover the repaired vessels. 2 weeks later, after the emergency surgery which was done on 17th of January, on the post-op day 14, the patient was discharged with satisfactory limb perfusion and wound condition. Following the discharge, there was a wait and watch period for the line of demarcation to become clear and control of inflammation, ensuring that the future debridement could be done to remove only the dead tissue while sparing the viable areas. Hence, patient was readmitted roughly around 1 month on the POD 34 after the emergency surgery. These are the preoperative images prior to the flap coverage. In the above images, we can see that there was a gangrenous segment which was well demarcated, involving the distal leg and the foot, with significant area of soft tissue loss. An exposed tibial bone with a granulating wound in the adjacent area, showing a transition from a non-viable wound to healthy wound bed for flap reconstruction. We proceeded with the plan of action. Traditionally, reconstruction follows the reconstructive ladder, progressing from simple options like direct closure and secondary intention to more complex options such as local flap, distant flap, and finally a free flap. However, in this case, we adopted the concept of reconstructive elevator, allowing us to directly choose the most appropriate action which was fit for the patient. However, given the extent of soft tissue loss and exposed vessels, the direct closure or negative pressure wound therapy could not be done. Why? Because already it was a revascularized patient, hence negative pressure wound therapy could not be done. The skin grafts were not chosen due to large complex area without a well vascularized base, and there was an exposed tibial bone. The local flaps and distant flaps, they were also not ideal as the zone of trauma was too extensive to provide a healthy nearby tissue. Hence, we straightaway proceeded to the free flap. So our final plan of action was a free latissimus dorsi muscle flap, which was done on 21st of February 2026. Now coming to why we chose a latissimus dorsi muscle flap. Since it is a large, reliable, well-vascularized muscle flap, so it will provide an extensive coverage for the extensive defect and exposed vital structures, since it has a huge bulky muscle tissue which was appropriate for the coverage. It has a long length of thoracodorsal pedicle with a good caliber. Additionally, our decision was guided by the Godina's principles on timing of microsurgical repair. Godina said he stratified the patients into 3 groups: early, delayed, and late. He told that the maximum and good outcomes came in the early period, that is in less than 72 hours of trauma. However, despite knowing that the free flap failure rate was 12% in the delayed period, which falls under our category, we attempted a free flap, based upon our clinical scenarios. This illustrates the latissimus dorsi flap marking and execution of flap harvest. The left image shows a patient in the lateral decubitus position. The elliptical dashed outline outlines the skin paddle and the underlying muscle to be harvested. The second image is the intraoperative stage of harvest, showing the muscle being separated from the deep fascia. And the third image shows the latissimus dorsi flap with its thoracodorsal pedicle. Free latissimus dorsi flap was completely detached from the back and moved to the leg, that is the recipient area. Microsurgical connection, that is anastomosis, was performed between the left thoracodorsal artery of the donor flap and the anterior tibial artery, which was suspected to be injured earlier. That was used in an end-to-end manner and not in an end-to-side manner. And anastomosis was also carried between the venocomitants of both the arteries in an end-to-end manner. In the accompanying video, we can see that we had taken simple interrupted sutures in an inverted manner so as to prevent the thrombus formation and have a good outcome.
What are the advantages of end-to-end over the end-to-side anastomosis?
Sir, end-to-end manner was done in this case since the anterior tibial artery, which was already injured in the trauma, so we could not do an end-to-side. So that is why we adopted end-to-end. And sir, in end-to-end manner, there are less chances of thrombus formation since the kinking of the vessel is less, which is more in the end-to-side manner. The latissimus dorsi donor site was over the flap was closed primarily with a clean suture line. This demonstrates the final surgical placement of the free latissimus dorsi flap onto the recipient site of the left leg and foot, ensuring a tension-free closure. This is the immediate post-operative appearance of reconstruction. Here we can see the color of the foot appears to be healthy and pink. Latissimus dorsi flap appears to be healthy, providing enough bulk for coverage. However, this is not the final look, as the exposed muscle will eventually require a split thickness skin graft. Hence, split thickness skin graft was performed on the post-op day 21 on 14th of March to achieve a stable closed wound. Our take-home message is, limb salvage is possible even in the devastating injuries with the right strategy and timing. Multidisciplinary approach is a key. Collaboration between plastic surgeons, microsurgeons, orthopedicians and vascular surgeons. Reconstructive elevator is often considered where soft tissue damage is extensive and the soft tissue injury is wide. Thank you.